what kind of tech do you have to rehab an ACL well?
To me, I think you gotta look back and say that great coaches existed way
Yeah.
before technology.
Good point.
And so great coaches were getting outcomes, Olympic gold medalists, really good results way before technology.
Yep.
And so we can go to it later and ask why. But I think that's the first thing. I'm also privy to the fact that we are becoming increasingly reliant on technology as a society. I mean, just think about GPS, right? I mean, if you're old enough to remember MapQuest, right? There's no doubt that GPS has eroded our navigational skills. So those are two things that I'm very aware of. I don't think we need to utilize technology to replace our decisions. I think there's always going to be intuition, experience, and value on clinical judgment and return to play. And if you're becoming increasingly reliant on technology to make those decisions for you, good luck.
Yeah, guys, thanks for listening to the True Sports Physical Therapy podcast. It took me forever to get this guest on, and it was well worth the wait. Today's conversation was with Dr. Jeremy Beyer. He is the Director of Clinical Excellence at True Sports Physical Therapy, and you're going to see why. Unbelievable ideas, really distilled down into actionable items. I loved this conversation, learned a ton from Jeremy, just like I do every day in the clinic. He is treating elite level athletes all day, every day. And now in this new role as the Director of Clinical Excellence, he is teaching our physical therapists, bringing their clinical levels up to par. And it's just fascinating to see. He graduated from University of Central Florida in 2019 with a degree in exercise science, and then went to my alma mater, which really taught him a lot more than it taught me, probably by virtue of the fact that he's a way better student, where he got his Doctor of Physical Therapy from the University of Maryland, Baltimore in 2022. He is a wealth of knowledge. I can't wait to hear what you guys think about this conversation. Here's my interview with Dr. Jeremy Beyer. Jeremy Beyer, I've waited forever to get you on this podcast. I want to start with some of your background so everyone knows how impressive you are. Tell me how you fell into physical therapy, why you chased it, and what brought you to here. And then I want to know why True Sports.
Yeah. So I think as a kid, I was always interested in the body. I was naturally a very curious kid, always asking questions. And, as a young age, I had an older brother. He was about 6 years older. We were always into sports. And I remember when he first got his first weight set in the garage. And, as a little brother, I was always trying to go out and imitate him and copy him. And I quickly fell in love with just trying to understand the body of trying to get stronger and build on muscle. And this would have probably been about 20 years ago, probably early days of YouTube. And so getting on the internet, looking on YouTube, and I came across an individual named Jeff Cavalier.
Yep.
This is like the early days of Athlete X. And he was a physical therapist talking about this hybrid model of sports medicine, performance, and kind of the science of building muscle. And I was like, man, I really, really like this. And so I really got into the nuances at a very young age. And eventually went on to college at the University of Central Florida, had some great professors there that really helped me develop my background in exercise science, strength and conditioning there. But always knew I wanted to pursue a little bit more of a higher level education. Physical therapy was kind of a goal. I didn't quite know what I was getting into in PT school, but I knew that there was this hybrid model out there that was being preached in its infancy days. But eventually applied to physical therapy school, made my way to Maryland.
Why Maryland?
It's a great question. I'm still trying to figure this out to this day.
Where else did you apply?
I applied to UCF.
Okay.
Actually, that was kind of my goal, right? I wanted to stay in Florida. I was from Florida. I was only a couple hours away from home. I wanted to stay at UCF. Smaller program, only 30 individuals. It was really, really great program. And I think it was a little bit more integrated with their exercise science. Got to the first round of interviews, but didn't do too well. And so then I was starting to look away, okay, how can I get out of state? What are some different areas? And so I started applying to Maryland. I don't really know why. I was just kind of let me just go for it. Applied, got an interview, flew up here on a Wednesday, was walking around, and it was one of the first schools that accepted me. And so eventually you're like, okay, let me just take this. That way I have something to bank on. And accepted it, and didn't really get into too many other places. And I was like, this could be good for me. And it turned out to be a great decision. I had some phenomenal professors there that kind of helped mold the way I treat. One of which you just recently had on the podcast as well.
Yeah, Rob Rowland.
And so I had some great experience at the University of Maryland, working in collegiate settings and getting good exposure to a wide variety of field and court sport athletes. And after I graduated, it led me to True Sports.
Okay. Why did you choose True Sports? Because I assume, just like you went through the process of choosing a graduate school, you looked at a number of potential employers. So what drew you here?
So, wrapping up graduate school, I had a lot of experience in collegiate level weight rooms where you have access to turf, weights. And so I knew if I was going to go into private practice, I need to have the facilities that allowed me to do the things I want to do. If I want to work on deceleration, acceleration, change of direction, I really can't do that in like a
An
small office
office.
building,
Yeah.
right? You just can't do that. And so if we're actually trying to prepare athletes for the demands of the sport, we need to have the facilities and space that we do. I think that's one. I think autonomy. I think I wanted to develop my philosophy around physical therapy and sports performance and preparation. And I never felt like true sports was like saying, "Hey, here's what you have to do," or "Here's the way you got to treat." I never felt like I was being micromanaged. So I think I had the space to grow, the space to develop my philosophy, the facilities, and then importantly, we treat athletes. This is what I do, and it's really hard because now I'm in the. It's interesting. It kind of comes full circle because now I'm actually doing more of the mentoring aspect of things. I'm taking on students, and they talk about like, what do you want coming out of your PT? And I was like, well, if you want to treat athletes, you have to surround yourself with athletes, and it's really hard to treat ACLs just by reading in a textbook or learn about ACLs from treating in a textbook. So you have to, you learn from your caseload just as much as it goes the other way around.
Yeah.
So I think a combination of those things is, and I was taking a risk, and it turned out to be a pretty good one.
Yeah, and the truth is, you were taking a risk. We're taking a risk.
Yeah.
We've gotten better. We've tried to minimize that risk
Mhm.
just with our interview process, getting you in for longer, getting applicants in for longer. We love hiring students, so that would have helped if you did a student rotation to see if it fits on both sides, like for us and for you. So we've come a long way on that. I want to go back to your interview at UCF.
Yeah.
Because I bet if you interviewed now for UCF, you would have a better interview.
Yeah, it's so hard because that's like,
You don't think so?
well, I'm going back. I'd hope so, if I'm any better now. But as you're going back, I mean, it's 2025. That would have been in 2019, and some of those questions you're just not prepared for, right? And it's like physical therapy. It's funny because
Do you remember any of those questions that
I
were like,
don't, and and it almost brings me back to there was a professor at the University of Central Florida. His name was Dr. Jay Hoffman. Really old school guy. He's peer reviewed, co-authored a lot of textbooks, really revered and decorated in terms of like the strength and conditioning and the literature that things. And I remember one of my final years as a senior, I had his class, and I was like, wow, this is really impressive. Like I'm just naturally want to be around these people. And I would go to his office hours.
yeah,
And, he's one of those guys, he'd be on the computer, kind of halfway listening to my question. And I'd be asking him, like, drilling him with questions.
Rob Rowland told me you asked a lot of questions.
So he'd be kind of looking at me and he'd have his glasses on. I'm like, he's not really listening to me, but I'm going to keep asking.
Yeah.
I had my list and everything. And then I think after one question, he pulls his glasses down. He looks at me. He goes, kid, what are your plans in life? And I said, well, Dr. Hoffman, I'm going to apply to physical therapy school. He goes, that's the wrong career. You're going to be bored. And I was like, well, I think it's a little too late for that. I already accepted. But I think it was a little bit of a disconnect going to physical therapy school because you want to become a sports PT and you want to learn about this model of sport performance and preparation, but it's so far removed.
It's a lot of garbage. So it's a lot of stuff that's not sports PT.
It is.
Yeah.
And I don't know if that's just because of the industry and the standard, right? They're kind of preparing you to be a generalist across everything.
They're preparing you for the boards.
Neuro, cardiovascular, peds. It's like you can't, and these fields are too complex to really dive into that. And so it's really tough. I'm not saying I have the answers, but I did feel that when I was going to physical therapy school, I always tried to supplement when I was learning in school with podcasts, audiobooks, just learning about what I can do, because I felt like going from undergrad to physical therapy school, it was like, man, these are worlds apart. And I'm going to actually almost decondition or some of my foundational knowledge is going to decay because I'm not actually honing in and tapping into some of those skills I've learned about. So it was certainly a challenge. It's certainly a challenge. And
I mean, I think there's a lot to unpack there. I remember, I think it's worthwhile, like as much as you can remember, like trying to demystify the interview process of graduate school, because there are a lot of people listening that are applying to graduate school, right? Or looking at PT school. I remember I was a very poor student undergrad, had a really poor GPA. Part of it is I had no idea how to study. I had no idea what my learning style was. And I just pulled a lot of all-nighters, failed a lot of tests because of it, most likely. So I was terrified I was not going to get in-state tuition and get into Maryland. And what I did was I knew I wasn't strong academically on paper. I researched the hell out of who might be asking me questions, who might be interview process. And the way Maryland used to work was they did like a group style interview where you went into a room with like 10, 15 other applicants. And they asked one question, went around the room, guys taking notes, ask another question, went around the room. Everyone's answering the same questions. So I tried to like stand out there. I remember one question they asked me, what magazine cover would you be on and what would the headline be? I had a decent answer to that. I think I said Sports Illustrated, Rosenblatt transforms the way sports rehab is done. Not a bad answer, but it sounded like everyone else's. Afterwards, I knew the guy's bio who was interviewing me. His last name was Hicks, Dr. Hicks. I think he went to Delaware after Maryland. And he was a Delaware graduate. And I knew that because I researched the hell out of who might be asking me questions. The reason I did that was so I could stand out. I stuck around afterwards and I said, Dr. Hicks, one quick question for you. I know you love questions, Jeb. What the hell is a blue hen? He's like, I thought about that. And like, he gave me some like cockamamie answers, my dad would say. But I'm convinced that question that he's like, oh, this Rosenblatt kid did his research. Like he actually wants to be here. By the way, that's one of the things we look for when we interview PTs. Like it drives me nuts when I say any questions and either they say no, or they say, how many days off do I get? Or they don't know about true sports. Like I wanted to show Hicks that I knew him. I wanted to learn from him. And he had to accept me to that school. That's like one thing that sticks out. Anything stick out from your interview process that you like why'd you get into Maryland and not UCF? UCF smaller program, but any other reason? You don't know.
They don't really tell you why. Is it because of the GRE, which has no relationship to school? It's really hard. I think at the end of the day, it's like, you have to in determining a school that's good for you. I think you should seek out the professors.
Yep.
Right. Instead of like, everyone goes on like US News or whatever it is and look at the top 50. That's like an arbitrary proprietary formula. Like seek out the professors that you want to learn from. Like if you want to go into sports physical therapy, make sure that they have some rock star orthopedic and sports physical therapists that are actually doing research and actually working in there.
And Maryland's come a really long way on that. Like Rob Rowland in our last episode, he was there when you were there. They have relationships now with the Terps and UMBC where you can get in college weight rooms and rehab rooms. They didn't have that crap when I was there. So that's amazing. I think one thing that I have seen propel you in your career since you've been with us 3 years now is that inquisitiveness. You are always asking, and it doesn't come from I'm trying to get my CI or I'm trying to get my clinic director. It's just you want to always get better. I think that really comes through.
Two things come to mind: curiosity and passion. And I think they kind of go hand in hand, right? I think passion has a little bit of a shelf life and inspiration, and you got to act on it quickly.
Yeah.
Right. And so act on it quickly. If there's things that are passionate about it, you might not be passionate about it in a while. But if you're passionate about it, you're going to ask questions and dive deep. Don't wait. Go. So you can start learning about that stuff and try to maintain those things. And so to me, it's like I never wanted to come out and just become the ACL guy. I love ACLs. So I'm sure we're going to talk about that. Or just the shoulder or just the, whatever. I wanted a wide exposure, right? This idea of being a generalist. And I think that's so awesome or such a great thing about working in an outpatient setting is you get to see a lot, which is exactly what you need because there's parallels from how you rehab different joints. And you can learn things from treating general pop to kids. And so I think when you have such a limited experience, it ultimately limits your ability or limits your peak or limits your ceiling and long-term growth. So I think curiosity and passion, act on them, try to think beyond just surface level stuff.
Yeah. Also, and you do a great job of this, is showing your passion and your curiosity. Because you could be curious, you could be passionate, but if you're not relaying that, it's going to get missed by whoever's interviewing you or whatever opportunities you have. A great example of that, I did your interview. I think I was the patient and you made me do a warm-up on the turf as part of your return to run or like prep for the session that you were going to put me through. And I was freaking smoked. I was gassed. I remember doing a bunch of marching and I was going to pass out. And what that showed me was you were ready to meet the quote unquote athlete where they were and challenge them. And that's something we're looking for. So you did a great job of like showing me the curiosity and showing me the passion. So that became a no-brainer. Like, yeah, we have to have Jeremy, regardless of whether we have a spot here or there. Like, you showed you need to be a true sports, and I think that's a great lesson to everyone listening. Let's dial it in more specifically to talk some clinical stuff. Thanks for that background, Jeb. Awesome job. Okay, when you think about ACL rehab today, what are the biggest gaps that you see in how most therapists approach ACLs?
Yeah, no, that's a great question. I think we can kind of break it down by phase. Maybe we can go through each one of them and kind of first highlight the gaps and then maybe circle back on how to fill them. I think if you're going to correctly solve these problems, you first need to identify what they are in the first place. And so we can go through early stage or maybe the acute, subacute. By now, I think everyone, or hope everyone, has an idea or prioritizes the value of extension.
Yep.
So assuming we're getting extension back, because if you're not getting that, I think we have bigger fish to fry. I think we struggle as an industry managing quad cross-sectional area, patellar tendon, quad grafts, and managing inhibition. And I think a lot of what we do during that acute and subacute phase influences that mid to late stage.
Yeah.
So there's a host of reasons why we get these things, but I think what's important to realize is like, what are some strategies that we can do early on? What are from a practical thing we can do and intervene from a very early stage, whether in pre-op or early stage post-op? I work with a lot of middle school, high school individuals, a lot of females, probably 60 to 70% are females. That's just consistent with the ACL literature on ruptures. But it's really challenging because you're taking an individual who has sometimes never lifted a weight and they don't eat like an athlete. And so now you're asking them to learn how to lift weights, but then fuel their body in a way that's conducive to putting on muscle. So I don't have a strong nutrition background, but I appreciate the importance. And so there's two recommendations, one strong recommendation, and then one thing I've recently started to influence on is the importance of protein, right? And so make sure you're getting 0.8 to 1 gram of protein per pound of body weight. I think that's a non-negotiable. It's pretty consistent with the literature. And I think that's just, if most people don't even get anything close to that. So whether that's supplementation with protein shakes or additional meals or whatever, but for females and males specifically, because why do we not want to be in a protein surplus when we're going into recovery?
You have to be.
Right, you have to be, right? And it's like, that's a simple thing. I just don't think we talk about that enough.
Totally.
The other thing is, one thing I've started to go into recently is creatine supplementation. Creatine is probably the one supplement I'll even talk about just because of the industry of supplementation, but there's a lot of research and evidence to support that it's healthy in kids. And so if we think about the role of creatine as it relates to energy production, and particularly those forceful and max effort contractions, I think one of the things that we do a lot in early stage rehab is NMES, and we see a lot of that quad fatigue, right? And so if we can do some creatine supplementation to help minimize some of that quad fatigue during early stage, I think that's incredibly important. So from a nutrition standpoint, the other thing I'd say is strategic use of BFR. I'd say my approach to BFR is I'm quicker to introduce it and quicker to get rid of it than most. I think a lot of individuals wait a little bit longer than hold on to it when we really need to be doing more traditional tried and true strength training. And so as far as introducing BFR, I think a lot of people will wait like till 2 weeks.
Yeah.
I think that's a little bit too long, right? I think that's just too long. I think most of this atrophy starts to set in the first couple of days to a week. And so my approach to BFR is more so around that 72-hour mark, more so on the clinical appearance. Are they still draining? Are wounds clearly? Are wounds starting to close? Are they off their medication? What's their alertness? And is their knee, relatively good? And then we start to introduce it, even with just like NMES or doing some sort of assisted short arc quads. But that BFR, just so they can start feeling their quad and getting some sort of, cross-sectional area, or at least working towards that, I think is incredibly important.
Tell me what you mean by cross-sectional area.
We're talking about like the muscle thickness, the size of the muscle.
So hypertrophy.
Hypertrophy. Yeah. That's what I'm talking about. Yeah.
Okay.
Which is, Yoni, it's going to be real. It's huge, right? Because our muscle cross-sectional area is proportional with our force output. And so when we add additional proteins, we're able to produce more force. So it's incredibly important that is going to factor into our strength down the road.
So if you're, I totally agree with what you're saying. Not shockingly, if you are not hypertrophying or working towards hypertrophy,
Mm-hmm.
you're setting your patient up for a disaster down the road. Like you said, this early acute, subacute phase will directly affect what happens mid-stage rehab. So if we're not working hypertrophy, we're going to have an atrophied muscle, obviously, the reverse, and that's going to increase loads going through their debilitated tendon if they're taking the middle third for their tendon. That's going to lead to a bunch of anterior knee pain. So that makes total sense. How do you pitch a 14-year-old girl, 15-year-old girl on, I'm going to put a tourniquet on your leg 72 hours post-op? What's your sales pitch?
Yeah, I think you start with why, right? And you tell them that, look, hopefully you have some time with pre-op and getting into it, but you tell them that like cross-sectional area or muscle mass is really, really important. And so for the next 9 to 12 months, putting on muscle is going to be one of the most important things that we do. We can already start to see, usually by the 72-hour mark, that we're starting to lose some muscle. We're going to apply this cuff, this tourniquet around your thigh. It's going to make your muscle work harder. You let me know if it's too much. We'll work it down. I really don't need to get into like the nitty gritty of like the mechanisms and we're cutting off blood flow. But yeah, like I tell them, hey, if you're getting any sort of numbness or tingling, let me know. If it's too uncomfortable, we'll go. We don't really go full blast immediately. We're just assessing it and making sure they feel their quad. And usually the response is like, okay, great. They trust you, right? Yeah. And I think so they trust you, but then they'll also be like, wow, I started to feel my quad. Wow, my quad feels really tired. And it's usually a pretty cool experience at 72 hours, and now they're starting to already kind of like prep it versus waiting for 2 weeks. I just think that's just a little bit too long.
Yeah. Rob made a great point. Dr. Rob Rowland on it teaches patients what hard work feels like. So it kind of resets their bar as to how hard they should be working. What does hard work actually feel like? And the positives there. I think there's a lot of psychological benefits that we don't necessarily hit on. I think that's a great pitch. Like you don't have to get into the weeds. God knows you're able to if the patient is asking for it. But this is the way we do ACL rehab. You want your knee to work better. We're going to put a tourniquet on your leg. It's not going to be the most comfortable thing. It's going to make you work much harder. I think that's a great way to pitch it. When do you lose it?
BFR, it's more about, okay, so when do we apply BFR in the first place? Why? And to me, there's 2 reasons. The patient is load compromised, whether that's due to biological or surgical factors.
Load compromised meaning they can't put more load through it?
We are wary about the amount of load that we want to put through that joint.
Why?
For whatever reason, surgical, repairs, healing, maybe we don't want to disrupt something. We just want to limit or constrain the absolute or relative load that we're putting through that.
I don't think that doesn't have to do with their ACL. That has to do with if you put enough weight on a back squat, let's say, or on a knee extension machine to induce hypertrophy without BFR, it's going to hurt or they're going to cheat. And so the reason we can't load them up is not because of their surgical intervention. It's because of either their pain or their movement patterns.
Yeah, I would agree with that.
Okay.
I mean, what are we assessing, right? Because we don't really have access to go and do this advanced imaging. And, so yeah, we're always typically we're relying on, those clinical symptoms, signs and symptoms. So yeah, so pain is a great one. I think your body's really smart and knows what you can and can't do. I trust pain a lot. And then I also think, again, swelling, edema, but regardless, okay, so say BFR, it's going to allow you to get a stimulus at a much lower load. And so say you have say you're working on a knee extension, you still don't want to do a max effort quad contraction, maybe not because of the ACL.
No, but their patellar tendon.
But if it's, their patellar tendon, their tolerance for fear, their inhibition. So I think these sort of things. And 2, maybe that is protective at that stage, right? Because pain is protective in the early stage. So maybe it is putting too much strain on the ACL. I agree with what you're saying. We just don't really know.
Okay.
Right? I think, so that's, I guess that'd be my stance on that.
Okay. So then when do you make the decision to get rid of the BFR? And why?
So I make the decision to get rid of BFR based on how they're progressing and tolerating, right? And so typically that comes anywhere between 6 to 10 weeks, depending on where they're at and how they're going. Sometimes with like meniscus and there's more intricate structures involved, we got to be a little bit more safe, quote unquote.
Slower.
To me, I like to get rid of it because it's just one more variable, right? It's just one more variable we got to manage. When I think that there's so much research on how to build muscle and how to get stronger within the absence of these, and it's like I don't really need it at that point, right? And so if I can do BFR, or I can just do a high rep set and probably get a very similar stimulus.
Yep.
So I think we can kind of transition to doing without it versus saying, wait, should I use BFR? Should I not use BFR? Should I use it? And so I think you just need to have a really strong rationale for why you're using it. And to me, the biggest rationale is going to be in that acute to subacute phase, when there is a lot of biological healing, a lot of swelling, pain, et cetera, et cetera.
Okay, that makes a lot of sense. What's your rep range when you start BFR?
Yeah, I think if you're just getting started, I think people look for this magic rep range, but the classic one is the 30, 15, 15, 15 approach. I think that's fine. I think what's more important, whether you do 2 sets of 15, 3 sets of 15, whatever, I think the goal of hypertrophy training is to get close to failure. And so you want to start seeing that contraction speed start to slow down, right? That's a sign that fatigue is kicking in and that they're having to recruit more muscle. So to me, it's like 1 to 2 sets to failure, right? Because, if you go back into the 30, 15, 15, 15 approach, usually those first 2 sets are prep sets, and it's the final 1 to 2 sets. And so that's also true with my approach to hypertrophy training across rehab, is that 1 to 2 sets per exercise is probably good. Now, depending on how heavy you go, the first set might just be a warm-up set. Because say I'm going to go up to, 150 pounds, and that might not feel good right away. But if I do a couple warm-up sets, now I'm neurologically ready. I'm prepared. I feel like that. And so that's my work set. So I think warm-up sets versus work sets are an important concept. But yeah.
Just to get to fatigue is the point, because that's going to create your growth stimulus.
With hypertrophy training.
With hypertrophy.
Yeah. And then, we can get really nuanced about how close to that failure you need to get. But if you're getting in within, a couple reps of failure, 2 to 5 is probably fine. You don't need to go to failure because there's fatigue associated with that. But again, getting close to failure is important. Proximity to failure.
Okay. That makes a ton of sense. Now, you're seeing this patient, let's say 3 days a week early on. I think therapists are really good about session 1, eval post-op. You got to get extension. You want to introduce them to their quad, right? Fine. What does your session look like visit 2 and visit 3 of that week 1?
The same. It's a lot of the same, right? You're just gradually progressing those factors. But, it kind of brings up a point that I was going to make about the quad. And so extension, I hope this is not a hot take, but if it is, whatever.
I hope it is a hot take.
So extension is incredibly important from a range of motion. And I see a lot of therapists doing exercises to contract their quad in full extension.
Yep.
And I'm not saying that there isn't value in that. I think from a neuromuscular control, I think it's important to work on. But if our goal is to load the quad, we want to put it into flexion. And so to me, I'm trying to improve extension range, but I want to improve flexion range. So going to 45, getting 90. I want to have 90 degrees of flexion by the end of the first week. Because it's like the way analogy I like to use is like, say you're trying to contract your bicep. And I said, all right, now go into full elbow flexion. Now squeeze as hard as you can. That's really, really hard. And we're taking a patient who's in pain, inhibited. Let's put them in a position to succeed, mid-range, 60, whatever they can tolerate, and then have them start to build up with those long duration isometrics. I think that's a phenomenal way to start getting some quad input. And a lot of times we think that inhibition is specific to end range because we see it during walking, but that inhibition is consistent across the entire joint. And so we know this because we test, right? When do we test at 60, 90 degrees? And we see that there's asymmetry, they're weak in this position. So it's not like there's a terminal knee extension. I think a lot of times they lack terminal knee extension is because A, they're stiff, which is important, or B, it doesn't feel good. And so that goes back to getting that quiet knee. And so instead of just hammering extension, ask why they're limited to extension or why they don't like going into extension to begin with.
I think that's a really nuanced take. I think it's fairly a hot take. What you're describing is a length tension curve, right, of a muscle. And so you want to make sure that you are tensioning that muscle throughout the entire length, because that's going to translate better. So that makes a ton of sense. I also think it's important to point out, if a knee is stiff or a knee is not getting to terminal extension, you have to figure out why it's not getting to terminal extension. Is it a passive insufficiency? So you cannot push them into extension for whatever reason, scar, swelling, whatever. Or is it an active inhibition? And I think that cues you into what your intervention is. Like I always preach about why we're doing what we're doing. So if you're hammering them, if you're hammering them on things like quad sets, or by the way, even knee extension, but passively they can't get to extension, you can't put them there. Their knee's not going to get to extension. Doesn't matter how big you get the quad. I've seen big quads with stiff knees.
Yeah.
Right. So you have to determine, is it passive or is it an active insufficiency? If it's an active insufficiency, hey, I can put them there. They have extension. I can manually heel pop them. Then you realize, and they can't do it themselves, they have an active insufficiency. Then you got to be hammering quad. But if they have that passive insufficiency, you better be prescribing a passive intervention like a hang, prone, supine, whatever it is. Does that make sense? That's the way I look at it.
Yeah, I agree. I think too quick we jump to our favorite bag of tricks
Yep.
or our interventions instead of asking why.
Yeah.
It goes back to really zooming out. But I agree.
Okay, so if visit 2, 3, they look very similar to visit 1, or at least visit 3 looks like visit 2, when do you start moving them towards closed chain work? When do you start with your band walks? Like, when does the session change, I guess is what I'm asking.
Yeah, I think it depends on some surgical factors.
Let's say they're weight bearing.
Yeah, say they're weight bearing. I like to get them least weight bearing right away.
Okay.
Right. And so just kind of putting some load to that joint, helping restore some proprioception, kinesthetic awareness, things like that. Sometimes it's just weight shifts. And then a lot of times I'm not doing a lot of movement, squats. It's, I would simply say, all right, I want you to get into like a wall sit, and then we'll have a sit in a wall sit. I think a lot of people are doing a wall sit, but then adding load into a wall sit, right? Isometrics are such a great rehab tool that can be scaled across.
Why is it so great?
Well, it's a great question, because I mean, initially, I think there's going to be a lot of fear around movement. And so, you can really scale them to lower and high intensities. Sometimes if joints are irritated, they don't go through a lot of flexion extension. Also, from a late stage standpoint, you can get more load on the muscle and tendon unit with isometrics. And that just goes down to length tension relationships and understanding.
And time under tension, right?
Yeah. Yep. And so I think they're just a really good tool to start to build output, right? It's just the feedback you get from those, and the pain, they're typically well tolerated. So there's just a lot of runway you can get with isometrics. And I think understanding how to program them and utilize them in rehab at different points for different goals is really valuable.
Yeah. Okay. So back to one of my earlier questions, which is getting the patient to do something different than visit 2, visit 3. Like you mentioned how you'll get them weight bearing as long as their weight bearing is tolerated. But you don't jump straight to a squat. And what kills it really kills me. It's a pet peeve of mine. And when I say what are some gaps that we see, I think this is a major gap in therapists across the board, which is, okay, they're able to weight bear. They're able to activate their quad in open chain. Let's go to a squat. So they're activating their quad in closed chain. That makes conceptual sense. And those squats invariably look terrible. So you go to isometrics. When do you start getting into an active knee flexion extension moment in closed chain?
Yeah. So no, it's a very good point. I used to be one of those, right? I used to be like, because at some point in the rehab, everyone's going to squat, hinge, lunge. These are foundational movement patterns that we need at every point work to improve their capacity and their efficiency within these movements, right? That's important. But I think jumping to them, it's almost kind of like, all right, next, let's go. You mastered this. And so, you take the example of an inhibited knee, right? Of someone who has pain, irritation, swelling. There's a lot of compensation. And it's like, okay, that looks all right. Let's add weight. And all of a sudden their knee's swollen and I'm doing 40-pound goblet squats. Is that the best use of time? You said it, but not me. But yeah, I would kind of agree. I would just question that. And so I think getting them in a position and say, all right, now we're going to like a wall sit or something, or now we're going to progressively hold this one, control it. And you do that for a couple of weeks. Okay. Now they're looking a little better. They're walking a little better, right? If they're not walking well, how are they going to squat well?
Yeah. Good point. By the way, that's a throwaway line, but it's really important.
So we start to load that, and then, okay, now we can do that. Now we go a couple sets of body weight squats, slow eccentric, back to a wall sit. And so we're kind of contrasting these from a motor learning standpoint of saying, can we ingrain these newfound capacities, this access to strength into a foundational movement pattern? And then we go back and forth. And so, yeah, isometrics can be utilized for not just for compound movements, but isolation. And, we do that all the time to help improve. The ultimate goal is to improve the squat pattern.
Yeah.
But is jumping to the squat pattern what's going to improve that the most?
Maybe not.
All right.
So, okay, then what do you do with the patient? Because I see this a lot. They're handling their ISOs, their knees somewhat quiet. Okay, it's time to move to a compound movement. Let's start with a squat. And they're just living on their unaffected leg.
Typically, that tells you that, okay, there's two ways of looking at this. Is this a strategy or capacity issue? And that is a question that's always in my mind during rehab.
Tell me what that means. That sounds very intelligent. Strategy versus capacity.
Strategy meaning a technique. Is this a skill? Is this the way they just chose to solve this movement problem? Is it a lack of awareness? Versus capacity, is there a structural, it could be mobility. Is it a neuromuscular strength? Is it a cross-section area? Because those are basically what your individual that forms what you have, what you can utilize.
Yep.
It's your capacities. And so if you don't have the capacity to do a task, you're just going to compensate around it. And so I'm always asking, all right, can we cue this, right? With a dowel, with an overhead? Can we do some sort of neuromuscular technique to try to feed into that dysfunction? Or is their quad just
too small,
so weak? And so, you can kind of go through a process where you solve that. It's like, okay, now I put you on a knee extension and you're shaking at 10 pounds. This task is inappropriate. And so I think it's like, you got to think like a detective and have this investigative process.
Yeah. Very, very similar to what I was saying about active versus passive insufficiency. If you put them in their squat pattern and they're leaning all the way on their unaffected limb, you put them on a knee extension and they're shaking like crazy, they can't control it. Now you got to solve for that. You've identified the deficit. You got to solve for that. So to me, that looks like maybe very light knee extension.
Yeah.
You have to bring that quad up to par in order to handle that task, right? That's what you're talking about. What else can I do to get them there?
Yeah. I mean, I think there's another thing too. It's like,
but you gave me pause there. Was that a dumb question?
No, because I was kind of going back to a point. Well, some asymmetry is going to be natural in rehab. And so you always have to have, for your squat point, for your squat movement, is this asymmetry or this level of asymmetry acceptable at this point in rehab?
Yeah.
And so maybe during the first couple with the squat pattern, maybe it's not load. Maybe our week to week progression is symmetry, or I want to see you get into that squat position just a little bit better. So I think that, I don't want people to think that like you need to have this perfect, evenly just, symmetrical, squat, at 2 weeks. That's not going to happen, right?
Yep.
Your quad is at 50%. So there's going to be, right? And so they are still loading that leg. And I think over time, that movement should improve.
Yeah. Okay. So that makes a lot of sense. Let's go down the technology rabbit hole because, dude, I would say this is like Jeb's calling card. What kind of tech do you have to rehab an ACL well?
There's two things that I should preface this by saying.
Every question I ask you have 2 answers to.
It's just context and nuance. But to me, I think you got to look back and say that great coaches existed way before technology.
Good point.
And so great coaches were getting outcomes, Olympic gold medalists, really good results way before technology.
Yep.
And so we can go to it later and ask why. But I think that's the first thing. I'm also privy to the fact that we are becoming increasingly reliant on technology as a society. I mean, just think about GPS, right? I mean, if you're old enough to remember MapQuest, right? There's no doubt that GPS has eroded our navigational skills. So those are two things that I'm very aware of. I don't think we need to utilize technology to replace our decisions. I think there's always going to be intuition, experience, and value on clinical judgment and return to play. And if you're becoming increasingly reliant on technology to make those decisions for you, good luck. Yep. You're going to get bad outcomes. And so this is why experience during return to play cases, it's so valuable, so critical. Now, as far as technology that moves a needle and how do we, admit that really moves a needle, I'd say it needs to satisfy some criteria. First, I think that it needs to answer a very specific question. If it's not answering a specific question that you have in rehab,
then what are we doing? Yep.
I think it needs to be practical. Right. It could answer a great question, but if it's not going to fit in with the flow of a treatment session, or it's not going to be practical with the space,
or it's too expensive,
or I'll let you make that call.
Yes.
Practical. And I think it needs to be simple. And I think this is where a lot of data or a lot of the sports science companies have come a long way, right? Making data analysis much more intuitive, appealing, and easy to visualize. So I think it needs to answer those things. I think it needs to answer a specific question. I think it needs to be practical, and I think it needs to be simple. Now, all that to say, I think my specific question in rehab is force. I think force is one of the few things that we have a lot of control over. It's a modifiable factor of how much force is this individual able to produce. And so two pieces of technology that really answer those force questions to me are handheld dynamometer, some sort of handheld to really measure isolated single joint or tissue capacity, and then a force plate, right, where we can really look into how is force being produced during a dynamic movement, like jumping, landing, plyometric tasks.
If you had to choose, so force plates,
I'm not going to choose between one.
You have to choose between one. And by the way, you have chosen between one for a long time.
You work with what you got.
Okay,
I think that's the biggest thing is that you work with what you got. You utilize, you be creative, you think outside the box. You don't just say, oh, I don't have this, I can't do this, right? That's a really poor mindset. But to me, I would say some sort of good handheld, right? Because so like a 10 deck, or I think even companies are getting a little bit more easier with the fixation and how we do that. But to me, it's because you can still compensate on a force plate.
Yep.
But I think you need both, right? It's not really either or, because again, you need both. It's comprehensive, right? I think we just can't look at, like, I think for a long time in rehab and ACL rehab, we just looked at just the quad. And it's like, how well does that quad integrate into acceleration, deceleration, change of direction, dynamic tasks? Like, that's a whole nother ballgame.
Yeah.
And so I think we can water it down and we can simplify it, but without both, we need to be comprehensive.
Yeah. I mean, you make a good point because, like, I've definitely seen in my limited experience, athletes, like, let's take it back before tech, athletes that would smack a triple hop test or your noise hop testing and go out and re-tear. So, like, we're missing something there. Okay, so now let's try to figure out what we're missing. So out come the handheld dynamometers, and we're seeing that, yeah, this athlete might be able to pass the test we're putting in front of them, but that test is not indicative of re-tear rates or return to performance, et cetera, right? So a tin deck or something like that should help us along that way. Then once we're able to measure that force and we're still struggling with outcomes, to your point, we're only looking at that muscle in isolation. We're not looking at it in the entire kinetic chain. That's where force plates can come in and put those worlds together. I think you also make a good point. One without the other sounds pretty risky to me, because I think they're a great compensator and they're going to look good on the force plates because they're an athlete and they have motorically figured it out. Or they're not producing enough force. Like, you need both of them to isolate and figure out where it is it's going to guide your session.
And I'll even take that one step further. Those alone aren't enough, because just because you can kick well on a quad test and just because you do well in a single vertical plane doesn't mean you're going to do well in a chaotic environment with changes of direction and really a lot of chaos. So I think there needs to be layers of your assessment, and you need to have a really good way of analyzing, coaching, and influencing movement. And that's why we're all interested, right? I think it's, what keeps me coming back. It's part of the puzzle and the complexity. I enjoy it.
Yeah, no, it's a massive puzzle. Okay, so let's apply those principles to return to run. Okay. How do you determine when your athlete is ready for a return to run program?
There's two ways of looking at this. I think you can look at it from the capacity, and then the prescription. So the capacity and the prescription of how you actually do that. I think we've gotten away from a time-based approach, and I hope everyone by now is doing some sort of criteria. And so I still think from a criteria standpoint, a lot of your clinical signs and symptoms reign supreme. Extension, swelling, range of motion, tolerance to gait, ADLs, things like that. I think that's tried and true. From a capacity standpoint, I think you want to have a lot of those foundational loading parameters we talked about. So are they squatting? Are they hinging? Are they lunging? If they can't lunge well, chances are the quad, that's a huge.
Where do you usually see deficits in their lunge patterns?
Usually in the back leg.
Yep.
They don't like to go in the back leg. They start doing some wonky things. It's actually not the front leg, but
So why is that going to matter?
Well, it's indicative of a quad deficit, of a quad that's not handling load well, which is going to manifest itself during running. So I think foundational movement pattern, squat, hinging, lunging, they're doing well with their weight training, able to handle some external load. Hopefully we're doing some sort of objective testing. I
was going to say, I love your first answer because it's qualitative in nature.
I think we got to have both.
Yep.
I think going back to your testing, we're getting so into the objective, but quad testing, symmetry is not that important to me. It's not that important at this stage. I think from like a relative or like an absolute number, or I'm sorry, like a torque to body weight, I think a 2.0 to 2.2 is a pretty good minimum. I think if they're under that or in that 1.5, you're going to start to see that show up in lunging. And to me, it's like, why are we running if we don't even have these base foundations yet? So I think that is probably a good from a criteria standpoint.
Can I make the argument that they have pain lunging, let's say rear foot or in their rear leg?
Mm-hmm.
That range of motion never shows up in a jog.
Yeah, the range of motion does. And
the range of motion doesn't. So I'm thinking like we have an endurance athlete, a cross country runner, let's say, tears their ACL. They're fiending to get back running, to sweat, get their heart rate up, etc. You want to give them some taste of return to run, but they have pain when they lunge. That lunge doesn't show up. Is there ever a scenario where it's like, okay, we can still put you back to a return to run and start filling in the gaps? Or am I asking for trouble?
I think it's asking for trouble, right? Because you want to have a reserve of strength, right? And I think that's a body weight lunge is not asking a lot of that knee. And so even though the range is different, I think the demand on the quad is going to be somewhat similar, right? I'm going to speculate on that because I don't think I've had the test to see the lunge, but that's kind of more of an experience. But to me, it's like you got to have a foundation level of strength, right? And so I think if you don't have that, it's gonna result in compensation. And then two, during running, there's deceleration depending on the speed. Are you going downhill? So you want to have well beyond the capacity that you need to run, because when running, we're doing something over and over and over again. And two, you might start to fatigue. So I think it is a good rule of thumb. You want to have good quad capacity before you initiate running.
Okay, that makes sense. Go.
The prescription part.
Yeah, please. That's where I was going.
So I think I'll take a slightly different viewpoint here than maybe how conventional PT does it. I don't want to say conventional because I don't think it's wrong. It's just maybe my slightly different viewpoint.
Just not right.
I'm not saying that. So if you're like most PTs, you probably learned about like a return to run or like some sort of return to run handout where, it starts with a walk, it's in a walk jog, and then it kind of progresses on, and then you kind of end with like a 2 to 3 mile just jog. That approach never really resonated with me for a couple reasons. The first is that I'm not a huge fan of continuous steady state running for team sport athletes, right? Even if they're in a high endurance or a lot of running, usually it's some sort of intervals, a burst, an acceleration, a jog, followed by a walk. And so I much prefer tempo runs over just steady state running. So to me, I'm like, I don't really like that idea. I don't think it's representative of the energy system and the demands that go on during sport. That's the first thing. Two, if you look at the way that a lot of team sport athletes run, there's a lot of characteristic or default movement patterns that show up. Large braking steps, excessive anterior pelvic tilt, forward lean, what we call backside mechanics. And so a lot of these individuals that play team sports, they're not great runners. They're so used to dribbling a ball, handling a stick, or whatever, having some sort of implement in their hand that they don't really, never been coached how to run. And so we take an individual, those two things, couple it with the fact that they now have a quad deficit, they have an asymmetry, and now we're going to expose them back to just like, go jog. To me, I just wonder if there's a better approach.
Okay, so, well, you're saying there is. What does interval running look like to you?
So tempo runs.
Tempo runs.
Yeah. Tempo runs they're popularized by track and field coach Charlie Francis. And so essentially a tempo run is a submaximal run. It can be intensive or extensive tempo. For me, extensive tempo is going to be 55 to 60% of, like, say, maximum, of your max effort. So it's more submax. Okay. And then you may do that.
Extensive,
meaning more volume, duration based. Okay. And so you're going to do that somewhere depending on the duration distance you want to go. It's going to be specific to the athlete in the sport. So for an extensive for football athlete, maybe 50 to 100 meters or yards. Versus soccer, it might be 200 to 300 because there's a little bit more of an aerobic and endurance, a distance approach in soccer but you're doing more submaximal. So say I'll have you do 10 or 12 times 50 yard runs, submaximal, maybe 15, 30-second rest in between, work rest intervals 1 to 1, 1 to 2, play around with it, but that's a way to build up. That's tempo runs, right? But what I like to do, or how I like to approach return to run, is use more of a skill-based approach to introducing running. And so I talked about or alluded to a lot of those default movement characteristics or habits that team sport individuals fall back to. I like to utilize what we call like running drills. And so we can kind of talk about those, but skipping variations, dribbling variations. These running drills are locomotive drills that can work on posture, foot placement, how they interact with the ground, elasticity, things that I think are actually going to promote enhanced movement quality during upright running, etc.
Yeah.
So I think we can start with skill, right? Short distances. But once they learn that, we can program those over 20, 30, 40 meters to get that aerobic benefit. And I'm not saying we just need to do that instead of jogging. I think we can do both, but I just don't like just the continuous jogging approach.
Yeah. I think that makes a lot of sense. Can you give me some of those drills? Because I think we don't have a large enough library as PTs when we approach this. So give me some drills to work on and describe them the best you can. You mentioned dribbling. You mentioned skipping.
So I think there's a lot of skipping variation. I think people are more familiar with skipping than dribbling. Dribbling it's essentially a running drill. I call it a running drill. You're working through an abbreviated or truncated range of motion. And so there's levers that we can pull from a stride frequency standpoint. There's levers that we can pull from a stride length standpoint, from a shape, right, where we can control the amplitude of range of motion. So say over the ankle, over the calf, over the knee, and we can also control the distance. And so there's various ways we can manipulate this and say, all right, we're going to start off slow frequency, slow length, so more of a circular shape. And I want you to go 10 yards over the ankle, just dribbling, just getting some rhythm, getting relaxed. And then you come back, do it again. All right, that goes well. Now let's go over the calf. Now we can play around with each of those levers, and you can actually do 10, 15, 20 reps of those to get, 20 minutes of quote unquote conditioning while you're improving skill as well.
Now, listen, you're getting aerobic conditioning or cardiovascular conditioning, and that's great. And I do think that is a gap in our ACL rehab when we talk about return to sport. You're also getting, how would I describe it, like tissue endurance, right? The number of ground contacts is very high in that instance. And so you're allowing the entire system to accommodate to that force. I think that bodes really well for our return to sport. I also think this is the difference between sports physical therapy and Gen Pop or orthopedic physical therapy, because the way you incorporated their sport demand, that's a sign of a sports PT. Hey, a football player is going to run around this amount. Let's structure it around that distance for return to sport or return to play or whatever, as opposed to what drives me insane, like putting a football in their hand, and that's your only sports intervention. Putting a stick in their hand and working on balance and stuff like that. There is room for that, but if you understand the demands of the sport, oftentimes I think we make the mistake of just using the device that they compete with as opposed to mimicking the actual demands of the sport. So I think it's worthwhile.
Totally agree with that.
Okay, you have to promise me and the audience that you come back on this pod and we do just a force plate analysis pod, because there's so much that I want to go into with like the way you use force plates, how you simplify it, how you make it accessible. Like you mentioned, like it's got to answer a question, it's got to be practical, it's got to be simple. You've really drilled that down nicely. Give me a quick teaser on 2 metrics that you look at when you put an athlete on a force plate and why they answer those questions for you.
I'm a big fan of utilizing the ODS framework from I'll explain it. From Hawk and Dynamics, where you have metrics that describe your outcome, so jump height, things like RSI mod, metrics that describe your driver. This is going to be more your force and your impulse metrics, and then strategy metrics, things like time to take off, depth, things like that. And so we can couple 2 to 3 metrics for the O, 2 to 3 metrics for the D, 2 to 3 metrics for the S, and we can really start to get a snapshot or get a picture of what's going on during the overall movement. So I don't say I have like one magic metric, because I think if you go all in on one, you're going to miss the other.
Yeah.
So I think it's
just define those again for me. I think that's a fascinating way to look at it. ODS,
outcome, driver, strategy.
Okay, and an example of outcome is
jump height.
Okay, driver,
impulse.
That's what? That's your
force multiplied by time.
So what is that though? That's your engine? Like, do you have enough?
Yeah, so it's phase specific. So I have braking impulse and then I have propulsion impulse. And so if I look at my braking impulse, that's going to be the area under my force time curve. When I go to jump, I develop a force time curve, the force and the duration of that. And so the area under that is going to equal my impulse. So how much force did I apply over the time period that I would apply to that multiply is going to give you impulse. And impulse is very important for various reasons.
Okay, love that. And then S?
S is going to be your strategy. right? So someone uses a very narrow or a very narrow, very shallow depth
Yeah.
versus a deeper depth, time to take off. Those are kind of things that we look at to determine a strategy.
Okay, fascinating framework. There's obviously so much there.
Mhm.
I love that. Even though you tried to skirt the question, you actually answered it beautifully in terms of like the way you just have an outlook on
Mhm.
force plates, where they would come in, and what metrics you're looking for. So I love that. I'm going to jump to our lightning round.
Okay, let's do it.
Okay, the Eric Cressy lightning round. What is the most underrated exercise in ACL rehab?
You love these questions.
I love them.
You
I
love
love
these-
them
you
because
love,
you
like,
hate
they're
them.
so,
I love them
like-
because you hate them.
You put me in a corner, and you know I hate these questions.
You hate the corners.
I'm gonna go heavy knee extension isometrics, and I think everyone's doing isometrics, and I think they're doing knee extensions. I don't think they're doing heavy
Why is that so important?
because it's phenomenal at improving inhibition, tendon tolerance, developing force output. It's the common theme here is force, and so if we can really focus on interventions that maximize force output, good things start to happen.
Love that. What's the most overrated exercise in ACL rehab?
Man, I'm gonna get in trouble. Let me preface this by saying there's no bad exercises. Movements are just, it's only misapplied.
Let
So,
me tell you why they're bad exercises. There are bad exercises because you only have a limited amount of time.
misapplied, inappropriate. I'd
Fine.
say, yeah. So I'd say a sissy squat.
Okay, why? First of all, define it, then tell me why.
Define.
What's
A
a
sissy
sissy
squat. It's a squat variation where it's a super quad dominant squat variation where you're up on your toes and you're essentially squatting down and really driving the knees far forward wherever you can. And to me, it's a very aggressive display of quad and knee tolerance. And it's a little bit awkward, and so I think it could be a good test or a good way of revealing some of your strength. But when we're going through ACL rehab, I think people kind of like to bust out the most intense or advanced variations, like we kind of talked about early in the process. And to me, it's an awkward exercise. It's hard to scale when, if your goal is quad, which, why put them in a compound movement? Why not just do a knee extension and then work on the other facets of movement, of compound strength and movement quality that we talked about. So I don't think it's doing much to improve movement quality in those foundational movements. I think it's a very intensive quad exercise where it's like, why don't we scale this a little
and knee
bit better?
intensive, right? Like your knee is in a very compromised position there, and if it's not ready to handle load,
Yeah.
by the way, this is why it can be a bad utilization of the exercise because it might set you back 2 weeks.
Yeah. And I would say that, like, if you can do someone can do like a single like sissy squat, which is crazy. That is an ultimate display. Like, that their knee is ready. So I think also too, understanding that what exercises can serve as a test or a screen versus one that's like actually utilized to build muscle or build strength, to build those qualities that we care about.
Yeah, super important. Okay, close us out with the best advice you got as a new grad that helped you get to where you are today.
Best advice, I'd say getting comfortable with uncertainty. I think there is so much complexity and nuance and unknowns surrounding what we do. And I think one area that new grads struggle with is the ability to confidently express the uncertainty and everything that we don't know while still being able to come up with a strong and reasonable plan. I think that is very hard to do, but I think it's very, very important because it's like you start to understand there's limitations to what we do, and you start to understand your blind spots versus if you don't and you think that you can fix this and you can fix this, I think you're going to eventually get served a piece of humble pie later on the road. So I'd say getting comfortable with uncertainty.
Yeah. I love that answer. That is an awesome answer because I've seen you grow around very specifically that. I think when you are so analytical like you are, you're so data driven like you are, that when something falls outside of an expected outcome, I think normally a therapist would struggle with that. And you've really come to grips with, okay, this isn't where we want it to be today. You're going to get that next visit. You're going to create that buy-in. And like when you say being served a slice of humble pie, I believe was your quote, that's going to show up when the patient is like, therapist didn't really know what was going on. I'm out. I'm not going to give them that next visit. And you've come so far on that. It's really impressive to see.
One thing I want to add to that is that I focus on the process more than the outcome, right? I think that, again, if you talk about the outcomes, it's really, really hard to have a complete control of the outcome. And so I tell my athletes, let's live and die by the process. When it comes to testing, to rehab, when we get to testing, it should reflect the body of work that we put in. Let's all we can do is focus on the next foot forward, the next step, getting better. And I may not have all the answers for you now. I certainly won't tomorrow, but I'm going to continue to crack at it. And I also don't know what Yoni knows. I don't know what he knows. I don't know what they know. I know what I know, and I'm a coach to my knowledge and my best ability, and I'm going to continue to get better at that. And I expect my athletes to do the same.
Yeah, that's awesome. Well said. Jeb, thank you for joining us on episode 150. Thank you to everyone who was listening. Just tell us where we can find you, because you're putting up some great content now.
Yeah, I'm mostly on Instagram at jbayerpt. Try to do a good job of sharing some articles, and I like to read a lot. As you alluded to, I have a lot of thoughts in my head, so trying to put more out there and hopefully share some valuable information.
Well, we're all benefiting from it. The profession is benefiting from it. I see athletes every single day benefiting from your approach and your knowledge. Thanks for doing what you do. Guys, thank you so much for listening. Reach out to Jeremy. Tell him what you loved and hated. Tell us what you loved and hated. True Sports PT on Instagram. Thanks for listening.